We've been informed that at 9 o'clock sharp we'll have to terminate our session. We are giving the leeway of around a few minutes. At 10 minutes past 8, we'll be starting our session. I think now the room is starting to be filling up. So sharply at 10 minutes past 8, we'll start our session. So kindly, those who are at the back, fill up the front rows so that our session can be relatively filled. Thank you very much. Good morning again. This is the Zanzibar Health Forum. Our main theme for the session will be promoting disease prevention and health promotion for sustainable universal health coverage in Zanzibar. My name is Mohamed Dahoma. I'm working with HIV and AIDS under the Department of Preventive Services within the Ministry of Health, Zanzibar. We have 4 panelists who will be addressing this primary theme on disease prevention and health system strengthening for sustained promotion. With us today, we have Mr. Abdulatif Haji. He's the head of health financing within the Ministry of Health, Zanzibar, an economist and a public health specialist. He has devoted about 90% of his skills in the area of health system strengthening, especially in designing and implementing the ongoing health financing reforms in the islands. His recent activities include the establishment of Zanzibar Health Service Fund, which is now starting to be operational, and the fund will provide health insurance scheme to former sector employee and the non-formal sector. And in addition, he has been involved with costing exercise of health and other health-related intervention. Mr. Abdulatif, kindly raise your hand to greet the audience. Thank you very much. Beside him is Madam Asha. She's the head of Quality Assurance Unit within the Ministry of Health, Zanzibar. And by profession, she's a midwife specialist, worked with an experience of about 18 years in different departments like ICU, maternity, and she's a senior midwife nurse. Has been an assistant matron at Zanzibar Hospital, and she has worked at maternity as in charge and midwife expertise with 3 different hospitals. She manages and care for pregnant mothers and newborn, and has been working with vast experience on complicated issues related to pregnancy during pre-labor. Thank you very much. We have Mr. Faisal Hamad Ali. He is an environmental health officer specialized in vector control, working in the Ministry of Health, Zanzibar. He is an entomologist and public health personnel and has devoted about 90% of skills in the area of community health. Together with his team, he's now in the run of developing a comprehensive national strategic plan for vector control in Zanzibar. Mr. Faisal, kindly, Karib San. Last to be introduced is Mr. Mwinyi Issa Mselem. Mr. Issa Mwinyi Mselem is a manager for the Zanzibar Public Health Laboratory. He's a seasoned medical laboratory scientist with a remarkable career dedicated to public health and malaria control. With over 3 decades experience, he has held various positions, including being a medical aid and the Malaria Control Project, Director of Training and Research at Zanzibar Hospital. He served as the chairperson for the Zanzibar Health Research Ethical Committee, and he's a coordinator of the Malaria Research Unit at Karolinska Institute. Karib San. Thank you, panelists. Thank you, colleague. We'll start the session. Each will have about 5 minutes to do the discussion. And the first speaker will be Mr. Mwinyi Issa Mselem, who will be discussing about the primary healthcare strengthening and to discuss how Zanzibar has focused and strengthened primary healthcare in disease prevention, promotion by giving example of intervention and best practices in primary healthcare strengthening for sustainable UCC in Zanzibar. Mr. Mwinyi, you can take the floor. We have 5 minutes.
Thank you, Chairperson, for introducing me. As Chairperson has introduced to me, my name is Mwinyi Mselem. I'm working in Ministry of Health and the Department of Preventive Services as a manager of the Zanzibar Public Health Laboratory. Protocol observed. I think most of you are aware about what is Zanzibar, where is lying Zanzibar in our United Republic of Tanzania. Maybe the information which I want to share with you, based on the census of 2022, Zanzibar population now, we are almost 1.8 million people. we are living in 2 islands. 60% of people, they are living on major island, Unguja, and 40% they are living in sister island of Pemba. Everyone knows that quality, Zanzibar is promoting quality universal health coverage in all health facilities. And this is a big priority for the Revolution Government of Zanzibar, and is implemented or emphasized by Minister of Health with all collaborators which we are working with them. It is clearly stated in the health policy of Zanzibar that quality universal coverage is priority of the Revolution Government of Zanzibar issues. The Ministry of Health, we have different levels of healthcare services. We have primary healthcare services and we have referral. In the primary health care services, we have dispensaries, we have health centers. In these areas, we are promoting disease in order to prevent disease to go to the complicated cases, to go to the referral level. By doing this, all primary health care units, through their sessions in the morning at outpatient, they are promoting and they are educating community, their patients at the health facilities, how to know the disease and how to prevent it. And this is cross over Zanzibar in all health facilities. We are doing these sessions of promoting diseases and preventing to the community. Ministry of Health has strengthening the disease prevention or health promotion by establishing the cadre which we call the community health volunteers. And this is not new cadre. We have it before. We had a community-owned resource persons in some areas which they have that responsibility of promoting disease and educating people how to prevent diseases. But also we have peer educators. They have worked in different programs in several years, but now Ministry of Health has established these community health workers or volunteers in large scale. Right now we have around 2,500 community health volunteers who are working at the community level by promoting different diseases, prevention, and they are making sure that the all community get this awareness of disease prevention. The Ministry of Health of Zanzibar, they are targeting to have community health workers at least every 250 people to be served by one healthy community health volunteer. Right now we have at least one community health volunteer is served about 700 people. But the target of the Ministry of Health at least to have every community health volunteer to serve 250 population. We have healthy promotion unit. Their roles is to make sure that all disease promotion is implemented in the community. Their major role is first to prepare the guidelines and the procedure, how the message will be delivered to the community. But also they are overseeing the supervision, how these community health volunteers, healthy promotion messages are taking care in the health facilities. And they are collaborating with the different programs. We have different programs. We have malaria, we have HIV, we have tuberculosis programs. So healthy promotion, they are working together with these programs in order to develop right messages and then to deliver to the community health volunteers, to the healthy facilities, also to prepare the posters and leaflets and to distribute in all healthy facilities as well as to the community. This is the major role of healthy promotion. And also healthy promotion, they are using different channels, media and newspapers, radio, television, to make this disease promotion and in order for community to prevent with the diseases. Coverage of the media which we are using in Zanzibar is crossover. We television we have almost 10 channels, and we are lucky. Some of the channels we get free of charge airtime in order to do the healthy promotion programs. We have more than 20 radios locally, and some radios are coming from mainland, but healthy promotion, they have responsibility, and they're collaborating with these radios to have all messages and disseminate our messages for disease preventions in all community. So, in a nutshell, the healthy promotion and disease prevention messages or programs are universal, and we are targeting to have all populations aware on every disease, on the same messages and in right messages on right time. This is how we are working as to promote disease and to prevent our community in our healthy workers and in our community. Thank you.
I think it deserves a larger round of applause. Let's see him clap. Thank you, Mwinyi. The key 5 take-home messages is that within the health sector of the Ministry of Health, there are service outlets ranging from PHC to centers, the functioning of the referral system, the investment on community healthcare workers with various names, be it peer educators, CHVs, COPs, cows, and everything, community-owned resource person, cows is community outreach workers. And in addition to that, the use of all forms of media, radio, TV, and social media in propagating information so that we can have SBC, social behavior change issues, and in line with programs and disease-specific intervention. Without further ado, I'd like to call upon Mr. Faisal. He's an environmental health officer, as I said earlier, and specialized in vector control. He will discuss the role of private sector in disease prevention and health promotion, and shall cite important examples that are existing in Zanzibar for sustainable universal health coverage. Mr. Faisal, the time is yours. Kindly proceed. Thank you.
Good morning, ladies and gentlemen. Okay, I would mix Swahili and English. Okay, as we all know that 25% of the healthcare activities are being contributed by private sector. And Zanzibar, as part of the world, is facing unique healthcare challenges. And the involvement of private sector can complement the efforts that they have been put in by the public and the NGOs. So, I would like to highlight some of the roles that the private sector has contributed in disease prevention and health promotion. The first one, we have these private healthcare providers. Yani kuna hizi hospitali za binafsi. Sasa hizi zinasaidia vipi katika issue ya disease prevention na health promotion? Tuna hospitali, mfano kama kule Zanzibar kuna hospitali ile ya Global au sasa hivi inaitwa Ampola Tasakhta. Na hisi wiki ijayo kuanzia tarehe 9 mpaka tarehe 11 wanategemea kufanya breast cancer screening. Kwa hiyo ile ni profitable. Wanachokifanya wao wana give back to the community. Sababu wao wanazalisha, wanaingiza pesa kwa sababu ni hospitali ya private, lakini kile wanachokipata wanahakikisha kwamba wanakitoa kwenye jamii free of charge. Kwa hiyo kuanzia tarehe 9 mpaka tarehe 11 watakuwa Unguja, wanafanya cancer screening, wanafungua camp, na kuanzia tarehe 12 mpaka tarehe 14 watakuwa Pemba. Lakini pia hizi private hospitals sasa hivi wanafanya integration ya immunization activities ambazo zinatolewa free of charge katika zile hospitali zao. Lakini pia tunavyojua kwamba Zanzibar ni kitovu cha utalii. Kwa hiyo investors wamekuwa wengi sasa hivi, wanakuja kuinvest kule, na ile inatokana na usalama wa nchi na mambo mengine. ambayo wakuu wetu wa nchi wana play part katika kuwashajihisha watu kuja kuwekeza Zanzibar. Kwa hiyo kuna baadhi ya hoteli zinatoa huduma za afya, yani kuna vituo vya afya ndani ya hoteli, na hizo huduma zinazotolewa pale ni free of charge, yani wao wanafanya kama ni wanatoa kwa community. Mfano ukienda kuna Kendwa na ukienda maeneo ya Fumba utakuta hizo hoteli ambazo ndani yake kuna vituo vya afya. Lakini pia kuna baadhi ya hotels zina support kwenye masuala ya wash. Mfano Jambiani kuna hoteli inaitwa Breeze, wao wanakisupport kituo chetu cha afya cha Jambiani kile. Wamejenga pale mnara, wameweka matenki na masuala mengine yale masuala ya IPC wanasaidia. Kwa hiyo ile organization committee ya kituo cha afya wameambua wao kwamba wakiwa na challenge yoyote, the door is open, waende tu pale wakaseme tuna shida 1 2 3 na watasaidiwa. Lakini pia tuna private sector nyingine ambayo ni telecommunication companies. Jana tuliona hapa kwenye ile project ya Mama kuna Vodafone Foundation ambao wao wamesaidia katika mfumo wa Mama. Ile ni private sector, lakini tunaona impact ya hiyo project ambayo wanaifanya kwa kupitia hizo mobile health initiatives. Lakini pia katika hii issue ya telecommunication companies, kipindi kile cha outbreaks, mfano kama kipindi cha COVID au sasa hivi tunategemea kupata El Nino. Kwa hiyo tunatarajia kwamba impact ya El Nino inaweza kusababisha maradhi tofauti. Kwa hiyo tunategemea kwamba soon tutaanza kupokea SMS. Naweza ukaambiwa pengine kipindupindu, ndugu mwananchi, fanya hivi na hivi na hivi na hivi. Kwa hiyo unakuta kwamba private sector inatoa awareness kwa jamii. Kwa hiyo hata kama mtu pengine yeye hana uwezo wa kuangalia TV kutokana na haya mambo yanayotokezea kila leo, ile SMS ambayo inatoka katika kampuni fulani ya simu inamwezesha yeye kujiandaa na matokeo ambayo yanaweza yakatokea muda wote. Issue nyingine kuna hizi tunasema private media. Tunapata airtime sisi kwenye vituo hivi vya serikali vya private, wanatupa airtime ambao pale tunaenda tunafanya mfano kama kipindi kile cha kufanya kama tuna campaign pengine ya chanjo, tunapata airtime kwenye TV na radios ambazo zinasaidia katika ku create awareness kwa wanajamii kuweza kushiriki katika zile kampeni zetu. Alafu pia kuna private research and development institutions ambazo hizi zinakuwa zinashirikiana na local authorities katika wanapofanya zile studies zao. Findings mwisho wa siku zinakuja serikalini na tunaweza kuzibadilisha zikawa kama ni policies kwa upande wetu. Kwa hiyo na wao pia wamesaidia kwa upande huo. Lakini pia kwa kumalizia, kuna hizi food and beverage industry, viwanda ambavyo vinazalisha masuala ya vyakula, na hapa nitatoa mfano wa Zanzibar. Ni nchi ambayo imezungukwa na bahari, na tunajua kwamba maji ya bahari ni moja kati ya raw material ya kutengeza chumvi, lakini chumvi ambayo inatokana na maji ya bahari ni non iodized, yani haina yale madini joto ya iodine, na tunajua ukosefu wa iodine katika mwili wa binadamu inaweza ikapelekea mtu kupata goita, ama kwa mama mjamzito pia inaweza ikapelekea miscarriage. Sasa kuna baadhi ya viwanda, mfano kule Zanzibar tuna Swahili Salt ambayo inasaidia wao wanatengeza zile iodized salt. Kwa hiyo kwa kupitia hii initiative yao ya kuongeza iodine katika chumvi, inapelekea jamii kuepukana na maradhi ya goita pamoja na hizo miscarriage ambazo zinapunguza ile population ya jamii, kwamba mama ameconceive anategemea mtoto wake akue, lakini kutokana na ile kitendo cha kula na iodized salt inampelekea yeye kupata miscarriage. Kwa hiyo kwa hayo machache naomba
Thank you very much, Faisal. Let's give a round of... Jamani, Kiswahili kitamu na kina ladha yake. But in principle, what Faisal has been speaking to us is that he has narrated the role of the policy of the health sector policy, where there's a component on PPP, public-private partnership, and the role of public-private partnership to turn back to the society, commit social responsibilities of returning all the goods back to the community from earning them. And the role of the private sector in taking care of pregnant women as a free of charge component, the issue related to research, the issue related to supporting salt makers in placing iodine so that we can all have iodinized salts. Existing of medical camps, Global Hospital and others, and the presence of private medical services within the hotel so that the visitors, the tourist industry is becoming protected and viable. Thank you, Professor, for taking us through. And now we'll be moving on to Madam Asha, sorry. Aisha is a big name. Madam Asha Mkamba, and she'll be taking us through the quality element. How is quality being assured? How is quality being monitored in service provision? Mama Asha, karibu.
Thank you. Good morning, everybody. For my part, also we'll use English. Yeah? So, as a quality officer in the Ministry of Health, we all know that quality is cross-cutting issues. That mean that it deals it take a wide range in the community. So we starting previously, we had document that use basic standard for health facility that explain how the infrastructure, resources in the community, in the health facility, which will help to promote quality, good health care to the facility or to the community. But we not deal only on the facility level, but also we going down to the community, and we developed the document that deal with the community issues also in part of the quality. So in that document, it emphasizes how community should live in their life to promote or to prevent themselves from the disease. So it is compiled many, mostly in the health promotion services, outreach services, and also health seeking behavior. Because all we know that if we promote healthy promotion in the community, we help them to prevent themselves and to control themselves of their disease, from disease, and to take over their responsibility themselves from the community to the household individually. So in that community, so in the part of the health thinking behavior, we emphasize community to have the ability, I don't have the should have the wawe na waamuzi wenyewe how to prevent, how to live the health life in their life before, or how to go out to seek health service to the health service in the facility. Yani tumeishauri jamii kwamba anapoumwa anatakiwa aende katika right place and right time find officially treatment. As we know that kwamba sana kwa jamii wanapendelea kutumia mambo ya alternative service katika kujitibu. Sasa this one hasa kwa upande wa kina mama, unakuta kwamba mama anapokuwa katika mjamzito lazima aende kwa yani mtoa huduma za kina mama, tunasema traditional healer, TBA, anakuwa anapendea kuwapa mitishamba ambao wenyewe wanasema zinawasaidia katika kupunguza mambo ya kuumwa, kupunguza kichefuchefu. Lakini tunajua kwamba zile mitishamba anapotumia mama sometimes zinaweza kumwathiri mtoto, kwa sababu ile hajakuwa na kiwango kile anachokitumia. Na unakuta mara nyingi unapomzalisha mama, unakuta hata ile laikwa yake inakuwa green, ama tumezoea laikwa iwe nyeupe. Lakini sasa kutokana na tangu mwanzo mimba inatunga mpaka anajifungua yeye anatumia mitishamba, kwa unakuta hata ile laikwa inaweza ikambadilisha. Pia tumewashauri pia na mama wanakuwa wanapenda kutembelea, yani anaposhikwa na uchungu anaenda kujifungulia kwa TBA. Kwa hiyo this book imeelekeza kwamba mama anapopata uchungu au anapopata shida lazima aende hospital akatafute matibabu ambayo yanatakiwa sahihi, ambayo atatibiwa na mtu sahihi na katika muda sahihi. So that's all, talking about the quality through the community.
Thank you very much. Let's give another big round of applause, please. The crucial take-home message is that quality assurance is a cut-across matter from facility to the community. The engagement of the community is important for behavioral change, early treatment-seeking behavior within the official treatment site and the use of effective use or proper use of alternative medicine paired up by or complemented with modern medicine is crucial for us to maintain the quality of life and access to proper services. Thank you very much, Madam Asha. I can see now the floor is filled up. I would like to take recognizance of Madam, I call her my mother. She has been with me since the first day I joined medical school in 1887. She was the senior lecturer in community medicine by then, and our principal, Dr. Fatma Mrisho. Mama Mrisho, please. Beside her, we have the president of the Tanzania Health Summit, Dr. Omar Chilo. Somewhere in the middle, we have our director for preventive services, Dr. Salim Slim. And lucky enough, we have our deputy director, Madam Fatma Kabole. This is a warm-up for this section. I know there are a lot of partners, we have colleagues, etc. Let's go back to wind up with Abdul Latif. He's a finance guy. You cannot do anything without financing. And so he'll take us through how can quality of prevention, promotion, strengthening of system be done with the limited resources that we have, or where can we get extra resources? Bwana Abdul Latif, the floor is yours.
Good morning, everyone. As moderator mentioned, that my name is Abdul Latif Haji. I'm heading the Health Finance Unit at the Ministry of Health, and I was supposed to talk a little bit about resources, financial resources vis-a-vis expenditures, but I will talk overall of how we finance our primary healthcare services in Zanzibar in a resource-constrained environment. We know that the resources are scarce, so we have to make sure that we allocate resource to make sure that we get the best buy or the best results or efficient. So we have several steps that we have done to make sure that the resources are allocated according to the needs of the people. So one among the milestones that we have achieved in Zanzibar 5 years ago, we have decided to revise our essential care package. As I think it's from the opening ceremony during the discussion there, one of the panelists, I think George Luhago, mentioned about in order to make sure that we allocate resource effectively, we have to define the minimum benefit package so that we can finance our healthcare services. So we have done that. We would like to acknowledge the support from the World Health Organization as well as Begging Center for Priority Settings that we done that exercise, and we have a defined list of interventions which includes, comprises about 302 interventions, including preventive, curative, rehabilitative, and intersectoral interventions, organized in 22 programs areas. Out of these interventions, 60% to be implemented at primary healthcare. So this is how we can see that how we prioritize the primary healthcare services in our package. So the package is highly cost effective with a ratio of around $198 per capita per daily availed. So once we are going to make sure that we have to allocate resources based on cost effectiveness interventions. Yeah. So what we have done is that we now, according to the National Health Account, total annual health expenditure is around $34 per capita. So we have to make sure that at the end of 2030, to achieve UHC, we need around $198 per capita. So it's a bit a long journey. We have around 7 years to finish this agenda. So we have to invest much on the primary healthcare. Out of this, the government of Zanzibar now finance around 53% of the health expenditure, whereby donor funding contribute around 30%, out of pocket is 16%. So these are the picture of how we have to make sure that we are allocating resources accordingly. So it's a kind of a gradual increase, because from $34 per capita up to $198 per capita around in 2030. So we have to make sure that we achieve this goal to make sure that we are giving the essential care service to our people. Another step that we have done to make sure that we allocate resources effectively, we did this exercise recategorization of primary healthcare services. So the main objective of recategorization assignment was to assess, identify, and classify the existing primary healthcare facilities in Unguja and Pemba into health centers and dispensaries as required by basic standard healthcare facility. We have in our quality unit, they develop these basic care standard healthcare facilities. So we have done this purposively so that we know that the resources are allocating accordingly from dispensaries to health centers and dispensary and district hospitals. So that is the second stage as far as health financing is concerned in our settings. Another step that we have done, we develop a health financing strategy, and one among the strategic areas is to direct financial resources to health facilities. So what we call direct health facility financing. As we know that now we have already the health service fund is in operation this October, so the funds will go directly to the health facilities, down the level up to the dispensaries. As you heard yesterday on a MAMA presentation, we were asked about the sustainability of resources, how we're going to sustain a MAMA. And one of the panelists mentioned about that in order to make sure that resources are sustainable, facilities will develop their micro-planning. They will plan. So they will include those resources so that a MAMA will continue to operate in Tanzania overall. The last steps that is not last, but it's a long time intervention. We have established Zanzibar Health Basket Fund, and this almost 58% or 90%, I can say, it supports primary healthcare. And unfortunately, the main supporter for Zanzibar Health Basket Fund was Danida, and they left. So we have the challenge of resources for the primary health care through Health Basket Fund. So we urge those partners to make sure that, or to engage this gain that we have done in Health Basket Fund to support primary health care service. So in a nutshell, that is how we finance our primary healthcare services. We finance people, we don't talk much, so I think it's enough. Thank you very much.
Thank you, Abdul. Thank you very much, Abdul. You don't talk much, but the coins make the noises. Thank you. Thank you for taking us through that. The allocation mostly is based on the PHC. A lion's share of it goes to the PHC, around 60% plus. They have averted experiences of diseases and disability adjusted life years lost, that is the DALYs, to a certain level. The allocation per capita is 34 now, targeting to 198. It's a long way to go, but still we are on the proper stage because, proper pace because the social fund is in motion to ensure sustainability of intervention. And lastly, what he said is that we have challenges in the basket funding because it was a one donor supported intervention, and that donor has left, and it has created a vacuum. We need to fill that vacuum. I think all the panelists have done their role. We can give them a major round of applause. And this is a two-sword edge. They have done theirs. Now it's up to for the audience to ask a set of questions. I don't know who is going to break the ice. Just your name and where you are coming from. We can start with the lady, and then Dr. Chilo. Is there a third person? Yes, and the lady over here. So the front row sitters seriously want to take on. Karibuna. Your name and your affiliation, please.
Asante sana.
Both languages are allowed.
Thank you. Naomba nitumie Kiswahili. Mimi naitwa Zamaradi Mbega, nafanya kazi na Farm Access. Tatumia muda mchache lakini sina swali. Nilikuwa nataka tu ku-react kwenye alichokiongea Abdulatif. Amesema kwamba sasa hivi serikali inatumia dola 34 kwa mwananchi kwa afya na target tufike kwenye dola 198. Nimepiga hesabu hapa haraka, hilo ni ongezeko la 482%. Sasa huo ni uchumi wa kwenye afya na share kidogo uchumi wa nyumbani. Ongezeko la 482% ni kubwa sana kwa miaka 7 iliyobaki. Clearly hatutaweza kufika pale. Mimi ambacho nilikuwa na shauri going forward, badala ya kuhangaika sana kwamba tunafikaje kwenye 198, je, tunaweza kubadili jinsi ambavyo tunatoa huduma za afya, tukaangalia kwamba hii 34 ambayo tunayo sasa hivi, je, tunaweza tukapata zaidi kwa hii 34 wakati tunasubiri serikali itafute hiyo 198. Kwa nyumbani ukiwa na shilingi 10,000 inaisha. Uongo kweli? Ukiacha 10,000 nyumbani inaisha. Na tukiacha 2,000 nyumbani tunashiba. Si sahihi? 10,000 inaisha, 2,000 inatosha. Je, tunaweza tukabadili tunavyofanya kazi sasa hivi kwenye sekta ya afya 34 itoshe. Hata kama haitoshi, kama tunapata 50% sasa hivi, tufike 70. Kuliko tuendelee kukaa tunasubiri 198. Asante, huo ndo mchango wangu.
Asante sana. Anasema tukate kitambaa au tushone koti kwa mujibu wa kitambaa chetu. Yaani tusipige tonge kubwa wakati mdomo wetu mdogo. That's the message. Let's be wise to spend and allocate and prioritize what we have for the intervention that will make changes and for the betterment of the service provision. Dr. Chilo, kindly proceed.
Asante sana. Mimi naitwa Dr. Omari Chilo. Swali langu ni kuhusiana na culture aspect, kwa sababu unasema unafanya promotion of disease prevention. But how do you blend it with culture? Kwa mfano, Zanzibar, they use a lot of, oily foods, but also a lot of carbohydrates. If you go to have a buffet, it's full of carbohydrates. And even the obesity rate is actually on the rise. So how do you integrate your prevention measures vis-a-vis the cultural aspect of the people that have been there?
Asante sana, Dr. Chilo. The role of culture vis-a-vis nutritional intake, full of carbs, and the BMI component out of it. Kwa hiyo mtashirikiana kulijibu na naweza tukachangia wengine, tuko wengi mundani. Madam, and kindly say your name because I've seen you the last 2 days, but unfortunately I did not get your name. Please introduce yourself.
Thanks. Hi, I'm Alice Christensen. I'm the country director of JAPIGO, and I also had the honor of being the co-chair of the Zanzibar Development Partners Group. I'm the outgoing co-chair. We handed over to UNFPA a couple months ago. First of all, thank you to all the panelists. It's such a pleasure. I think Zanzibar has a lot of energy and proactiveness. So I had two, I guess, comments. The first is, you know, the Health Basket Fund has been a call to the Development Partners Group. I think it's on almost every agenda, and we did have Danita present on kind of as they pulled out. But I think Danita has some very clear recommendations on how to encourage Zanzibar to strengthen some of the processes so that we can help with the Development Partners Group. So I'd love to hear from Abdul about that report and any actions that are being taken, because then I think if we are showing that actions are being taken, we can encourage more development partners to fund the Health Basket Fund. I understand it's a huge gap, and we're seeing the impact of that. And then my second question has just escaped my brain. So we held a panel yesterday morning, and Dr. Ntuli was on the panel, and he was saying one of the biggest things that he was proud of and had the impact on mainland Tanzania was the decentralization of funding down. And I heard you saying about the micro-planning, but I think that we have seen the impact of that where health facilities or districts are really able to prioritize, and with good leadership and governance and accountability, you're really able to see that impact. So I'd just love to hear also from Abdul about any thoughts on decentralization and this micro-planning that you're talking about, like with M-Mama. What is the funding source from that? Is that government? Is that the Health Basket Fund? Or how are we able to access that? Because I think on mainland, we've seen it's been very impactful on improving primary healthcare services. Thank you so much.
Oh, thanks. I think let's start with this one. Yeah, my fellow colleagues, there are recommendations, and there are the issues related to culture, and the last one is fully health financing vis-a-vis sustaining the gains that were accrued by basket funding, and what are the alternatives, because there was a report that was left to guide us to solicit or to sustain the gains of the basket fund. Who is going to start? Abdul?
Thank you for your comments and questions. I will start with Dada Zamaradi, and I will speak with Swahili as well, because you asked in Swahili. Umeuliza kuhusiana na kama moderator alivyosema wanasema mbuzi hula urefu wa kamba yake. Yeah, actually na sisi tumefanya hivyo wakati wa hii reviewing ya essential care package. Tuli develop criterias kwa ajili ya kuweza ku come up with those cost effective interventions. Now actually according to the WHO recommendations, in order to provide basic essential care service, we need $86 per capita, which is around $54 difference. Na hii it's a gradual. Sio kama just kwamba serikali itabidi allocate $198 per capita just in a year. Lakini tumefanya from 2021 to up to 2030. Kwa hivyo kutakuwa na, kwa mfano sasa hivi tuko 2023, sio 34. We are supposed to allocate around sina data kamili, lakini it's above $34. Kwa hivyo it's kind of gradual, tunakwenda kidogo kidogo, na of course budget inaongezeka, na sasa hivi moja katika recommendations tunazotakiwa kwamba we need to mobilize domestic resources, na sasa hivi mfuko wa huduma za afya umeanza. Kwa hivyo tutegemee kwamba tutakuwa ile pool yetu ambayo imezungumzwa kwamba wagonjwa na wazima lazima sote tuchangie. Kwa hivyo tunategemea kwamba per capita expenditure tunaweza tuseme inshallah tutafika $198 of course, lakini tayari tuna milestone kwamba mwaka huu we have to allocate this. Tuna lobby Minister of Finance to engage budget, mfuko wa huduma za afya. Kwa hivyo we can achieve that goal. Secondly, it's about Zanzibar Health Basket Fund assessment report, and of course, yeah, there were recommendations on that report. There was long-term, short-term recommendations, and we are working on that. Well, actually, one among the recommendation on the Health Basket Fund, long-term recommendation was to establish basic health service funds as our one of the country, I think it's Nigeria.
We have been informed that we have 5 minutes left.
Yeah, they've started this basic healthcare provision fund. So we are working on that, and the issue of accountability, of course, we need to work on it to make sure that the finance that are going to down there people are accountable on using those funds. And DHFF, yes, we have developed a facility financial management guideline. Within the guideline, there are steps in using the funds, including planning and budgeting, financial management, monitoring and evaluation. So within that guideline, it stipulates the allocation of the resources. 80% you allocate for medicines, 10% incentives, 10% administrations. So once these lower levels facilities they're going to plan, there's a guideline already we have developed. Thank you.
Thank you, Abdul. Anybody who would like to respond to Dr. Chilo's question? Thank you, Mwini.
Thank you, Dr. Chilo, for the question of how do we deliver the message in relation with our culture. Just I will give you a short example of what Faisal has said. We are producing salt for ourselves in most of coastal areas in Zanzibar, and it's cheap. The method is cheap and the cost is cheap. But the method which we are using, we found that salt which we are producing does not have iodine, and it has to be treated. So we are using different messages to educate people. They have to understand that, yes, you are saving money, you are producing for yourself, but we knew there's a problem in this salt, so you have to do this, and people, they are understanding and they are treating. Now, once when they produce salt themselves, they go to the healthy facilities and request for iodine, and they treat, and they are making sure that all people who are selling that salt is iodized. So our culture does not stop us to educate our people in order to make disease prevention. Thank you.
Thank you, Mwini. Just to chip in, Dr. Chilo, in 2011, 2012, there was the first step survey where the NCDs were measured, and the BMI, those people having BMI higher, more than 30, were more than 30%. It was more in women compared to men. And there's another one. Data collection has started, another step survey. That data collection has started. We'll hear about what the BMIs are now in place and what needs to be done. That's one. Two, there are efforts from Maisha Bora foundations that every month to remind people about exercising, calorie intake, and the like. And that is also another intervention to cut across the old myths that lazima ule kibaba, ule kisaga, ule hivi, taking more carbohydrates compared to taking more protein. And another factor is that there is an NCD unit within the preventive department, which works with the health promotion unit. And knowing that we are now observing a turn from infectious to non-infectious diseases, more efforts are being placed on NCD to educate and invest more on the younger generation and to the elderly as well, so that we swap from taking carb which are have some addictive tendencies so that we can move on to more calorie benefited intake. I think I must say thank you to all, the audience as well as our presenters for being together this morning. It has been a wonderful morning. Let's praise ourselves by a large round of applause. Thank you. Asanteni sana, please. Thank you all.
Hi.
we met,
Yeah, we have. You
in
look really
DPG
familiar.
session.
Yes, okay,
I'm
good.
Mohammed.
Nice to see you,
Me too.
Mohammed.
Okay, thank you.
So that was a great answer. I was actually going to see if you could speak up to the...
Either Mikumi or Ruaha. There's no session now. There's no session. No session coming. Until tea. Until tea, yeah. Mikumi and Ruaha only.
Good morning. Good morning, good morning. For the time being, there is no forums or sessions that is conducted here. So please, can you go to the keynote sessions at Ruaha and Mikumi Hall? Until 10:30, MDH will be here. You're welcome.